So good afternoon, and thanks very much for this kind invitation to the organizer. I have to find the slide before, and I give you the salutation also of all the Italian network of supportive care in cancer, that is the NICSO, that is very involved in supportive care, and so we are very happy to share and to receive hints and suggestions from all these experts coming here today. So the question is, if we should change our way of reporting adverse events during cancer treatment. We know the topical issue is the toxicities that we are able to find in the results of randomized clinical trials are really transferable to the next patient that is in our waiting room. This is the hot questions. And we know that clinical trials provide guidance not only for efficacy but also for safety. And the clinicians are used to employ these results to make recommendations, to describe the risks to the patients, and to facilitate also a shared decision-making when we are in front of our patients. But there are some limits of the randomized controlled trials that are published. First of all, that they are underpowered to detect differences in toxicities because the statistical part is usually set on the efficacy of the treatment arm. Moreover, often some anti-cancer drugs receive a fast-track approval. That is good to have new drugs in our armamentarium. But on the other side, we are not aware of possible late effects that they are not described in these trials. Or we are not aware of rarer toxicities. And moreover, we know that all of us, that when we perform a clinical trial, we are used to put in the trial only the most fit patients, you know. And so it's really transferable, the results of one trial to the waiting room where there are also patients elderly or with lower performance status. This is the questions. There are two wonderful papers published in JCO in 2013 and 2014 that they are able to describe how randomized controlled trials are able to find and to evaluate correctly the adverse event. So let's look at these trials. These manuscripts were based on the evaluation according to the consort, that they are the consolidated system of reporting trials, also for what concerns toxicities. And they evaluated if the data on adverse events are cited in the title, in the abstract, or introduction. If the authors employed validated instruments to report adverse events, how adverse events were collected and presented, if the adverse events withdrawal the withdrawal of the patient from the trials due to the adverse events are described or not, and if all the adverse events are reported or only the ones above a determined threshold, and if the discussion was balanced between the harms and the benefits of the trial. And so what did they find? In this first trial, first of all, the mean qualitative score, there was a score, the maximum grade was 16, and the mean qualitative score of all these trials was 10. And there was an higher quality when there was an industry funding for the trial, with intercontinental trials, in the metastatic setting, because perhaps the physicians are more accustomed to report adverse events, and when the authors reported in the conclusion something regarding safety. The other manuscript is very interesting because it's dedicated to metastatic randomized controlled trials performed in this period of time. The median completeness score, that is a quality index, was 8 out of 14. And they reported some heterogeneity in adverse event regarding the threshold rate, the fact that often only higher grade toxicities are reported and not only not grade 2 and 1 also, and that often these adverse events are reported with vague terms and not a specific terminology. It's the same with immunotherapy too. We know that this is a growing field in oncology. This is a very interesting review of the immune-related adverse event reporting in clinical trials, just appeared on the Annals of Oncology. What do the authors find? That also the reporting with immunotherapy was suboptimal, and there was some kind of heterogeneity. But the quality improved over time. There was an higher score with the trials reported in journals having an impact factor above 15, so high quality journals. And the most intriguing fact is that the duration of follow-up of adverse event is reported in only 30% of the papers. That is not optimal, because you know that this kind of drugs have adverse events that often last for more than 1 or 2 or 7 or more weeks. And so it is of vital importance to be able to collect and to catch the adverse event also after the end of the drug. And what about targeted therapies? Also, they are also a growing field in oncology. And there are several issues linked to these treatments. First of all, the quality of the measures and the grade of toxicity that are reported. Then the duration, that I call the third axis, then we can evaluate why. The late toxicities and the cumulative effects, and then the impact of the adverse event in terms of reporting, in terms of frail patients, compliance, and dose reduction. So let's go inside. First of all, I would like to start with these sentences reported in the conclusion in this wonderful paper by Ioannidis, that explain that we must no longer accept confusing lists of non-comparable percentages of adverse events for clinical or for scientific purposes, and that we must insist on better understanding about how numbers about harms were collected, where they came from, and what they mean. What they mean? I would like to give you the example of vismodegib. Vismodegib is a very effective drug for the treatment of recurrent or metastatic basal cell carcinoma, not amenable to surgery or to radiation therapy. In this first trial, published in New England Journal of Medicine, the author stated that the most common reason for discontinuation of vismodegib were disease progression in the group of patients with metastatic basal cell carcinoma, and the patient decision in the group of patients with locally advanced basal cell carcinoma, 25%. The reasons for these decisions were not documented. I think that a sentence like this is not acceptable to be published in a journal like New England Journal of Medicine. One patient out of 4 went out of the trial for his or her decision. It's not acceptable, because if you have a look to the adverse event of this drug, you can find that there is a lot of adverse event in terms of muscle spasms, alopecia, dysgeusia, weight loss, and this drug is typical of elderly patients, and it is assumed for several months. So the reason is this, is not the patient decision. Moreover, not all the trials are accustomed to report all grade toxicities. And if we record only maximum grade of toxicity or only grade above the threshold of the grade 3, we may neglect a considerable burden of lower grade adverse effect. And there is the question of the third issue, that is time. You know that usually we catch the frequency of an adverse event and the intensity of the same adverse event. but we are not used to assess the time duration of this adverse event. And so evaluating the impact of adverse event duration is important on patients' well-being. In particular for targeted treatments, because they are treatments that they last several weeks, months, sometimes years. And so it's important to know how long also an adverse event lasts. I would like to give you this example that is interesting about which toxicity worsens quality of life the most. In the first part, you can find a grade 3 diarrhea due to chemotherapy, for example, that is during for 3 days only. Okay. In the second part, you can find a grade 1 diarrhea that lasts several months. Okay, due to another drugs that could be, for example, multikinase inhibitors or an immunotherapeutic drug. I would like to remember you that grade 3 means more than 7 stools per day, while a grade 1 means less than 4 stools per day. That is 3 stools per day. So it is worse to have for 3 days 7 stools per day, or for 7 months 2 or 3 stools per day. Open question to you. There is another problem. What about recurring adverse event? When you have a look to the trials published, you can find that usually only the higher grade adverse event are reported. So this should be reported as grade 3. But the same patient had also a grade 2 in the following weeks, a grade 1 and another grade 2. But these are completely neglected by the results of the trial. So this is only a proposal. Are we ready for evaluating the toxicities of our patient with the area under the curve? This is very important also to be linked to another slide that I will see you at the end regarding the importance of patient-reported outcome. That could be really linked to this question. Another problem is what about the late effects? We know that if early effects can give poor compliance to the therapy, late effects may affect the long-term quality of life of survivors and may compromise the survival benefit from the therapy, regardless of disease status. Also considering that the number of cancer survivors has tripled over the last 30 years. But most trials failed to detect late toxicity. And why? I asked myself why, because also for myself, it is not used to collect late effects of our patients. Perhaps because they have too limited follow-up, or because we are accustomed to evaluating late effects of targeted treatments, or because we have not standards for reporting this kind of adverse event, or because the targeted treatments are explored in the metastatic setting in particular. And so it is difficult to evaluate late effects in this kind of population. But targeted treatment toxicity are underreported because the rates of adverse event may underestimate the frequency or severity of toxicities seen in practice. Just another example for this question. The case of cetuximab plus radiation therapy in head and neck cancer. This was the first trial published in 2006 by Bonner, evaluating the difference of radiation compared to radiation plus cetuximab. And apart from the efficacy that is well known, the authors state that there was no difference in mucositis or in radiation dermatitis between the two arms, but only, as obvious, in acneiform rash. Okay. Then several papers were published telling the contrary, because as you can see in these results, the radiation skin dermatitis is worse with cetuximab, but also oral mucositis and also weight loss. Another paper reported that concomitant cetuximab resulted in a 10-fold increase in the rate of severe transient dermatitis. And these are only some pictures published by the New England evaluating the importance of this kind of adverse events with radiation plus cetuximab. Moreover, we have to consider that we are facing with specific population of frail patients, elderly, with comorbidities, with low performance status. And we have a lack of information about the impact of this targeted treatment in these patients regarding toxicities. The next point, what about the patient-reported outcome and physician-assessed toxicities? We know that the scientific evidence demonstrates that health professionals underestimate the burden and the severity of symptoms in comparison to the patients. And that detailed PRO, patient-reported outcomes questionnaire, are able to discover more adverse events compared with unstructured reporting. These are only some of the papers published in the literature confirming this fact. And it is important to say that we are not fighting between a patient or a physician reporting, but they have to complement this kind of adverse event, because physician adverse reporting with the objective exam or clinical graded symptom or with analytic imaging or laboratory exams increase the specificity with the NCI common toxicity criteria. But there is also an important part linked to the patient recognition of adverse event, because the 10% of the CTC-AE are symptoms. And are we allowed as physician to report a symptom in spite of the patient? Because currently the patient experiences symptoms, then the clinician interviews the patient at the visit, writes in the chart, then the data manager abstracts the chart, converts findings to standard terminology, and then perform a manual data entry. So many steps to evaluate the adverse event. But perhaps, at least for the symptoms of the patient, there should be a more easy way to collect. So a new model of patient adverse event. I would like to give you another example, the example of palifermin and the value of patient-reported outcome. Palifermin was evaluated in hematopoietic stem cell transplantation and in the setting of head and neck cancer. And both of the trials were positive, according to physician-assessed mucositis, because palifermin significantly reduced the intensity and duration of WHO grade 3 and 4 mucositis in respect to placebo. Is all okay? Not all. Because when you evaluate the same trial regarding the patient-reported outcomes, you can find a difference. Through the oral mucositis daily or weekly questionnaires, in the hematopoietic stem cell transplantation population, the palifermin was able to improve the patient's self-reported mouth and throat soreness. But the benefit of palifermin in physician-assessed mucositis in head and neck cancer was not paralleled by a better patient-reported outcome. And so this is the meaning, because palifermin is approved in this setting, but not yet in this setting. And the patient-reported outcomes offers also the opportunity for labeling claims and are tools for comparative effectiveness. And recently, there was the development of the PRO version of the CTC-AE. And so coming to the conclusion, this is a just published paper. I would like to put as a suggestion for future common works. Because this paper evaluated validated the pro-CTC-AE in a large sample of cancer patients in several institutes in the United States, and also with patients having different performance status. They evaluated the frequency, the severity, the interference with the daily life, the presence or not of the symptoms, and the amount of some symptoms. And they built 7 surveys, each targeting a specific kind of cancer according to the typical adverse event. And so In conclusion, take-home messages. It is important to evaluate also lower grade of toxicity. It is important to have a consideration to the third axis, that is time, and to use new instruments for adverse event evaluation, at least for the 10% of adverse events that are reported directly from the patients. And this could be the link between the PRO CTCIA and the area under the cure that we saw before. Moreover, it's important to give an attention to the late effects and also to the cumulative effects of the drugs, and to evaluate the impact that these drugs have regarding the compliance to the treatment or the impact on the frail population. In the next steps, what should they be? First of all, we need to build protocol-specific safety plan for each study, and there is the importance of PRO in parallel with the physician-assessed toxicities. And so this is the proposal, because the pro-CTC AA that are recently validated in the United States setting lack of linguistic and cultural validation, lacks of validation in selected population, for example, with targeted agents or with immunotherapy should be the next step, and the lack of practical issues, time, costs, or change in practice thanks to the PRO CTCA. And this could be the idea for a European or a transatlantic cooperation with this trial. So thanks so much for your attention.